thank you for invitation, and thank you, Ralph. Thank you, everybody. Now, I will be probably have just half an hour. Probably try to be very quick. This is management of sickle cell disease or hemoglobinopathies, but mainly sickle cell disease in primary care. So I'm a hematology consultant leading the benign hematology at London Northwest Hospitals, and also lead for hemoglobinopathy. Now, my presentation will go quickly, short about some few things, which we think that is important for you, GP, and relations between secondary and primary care. It's just few words about epidemiology, then organization and setting in UK, and then genotypes and pathogenesis, a little bit about phenotypes as well, NC pod report and recommendations, and also acute and chronic complications. Probably good to know when to stop hydroxychloroquine, which many sickle patients are on. Vaccination program is important for GP, and when to refer to hospital, and management of acute painful crisis, and also just recognize signs symptoms of acute chest syndrome, which is the leading cause of death in sickle cell patients, and importance of a multidisciplinary team meeting and role of primary care in the management of sickle cell disease. So this is just a picture. I took it actually from Novartis Pharmaceuticals website, permission from them. I hope that this is a most recent epidemiology. So if you look at the sub-Saharan Africa, you will see that there is 12 to 15 million people there affected by sickle cell disease. And you can see another one in India, 5 to 10 million. And I think this others are related to immigration. So you will see in Latin America about 100,000 to 150,000, in North America 100,000, and in Europe about 52,000. But these maybe they omitted also a Gulf region. There are also sickle cell populations there, and in Turkey as well there are sickle cell populations as well. Probably this one from Hammersmith Hospital, a picture which probably illustrates better the epidemiology, which includes Africa, India, Gulf region, and Turkey, and slightly some areas in South Europe. So the main single mutations happening in beta globulin changing from glutamine to valine. Valine is the mutant protein, and that leads to cascade of problems when deoxygenated. So when hemoglobin give up this oxygen, it will be a lot of issues with attachment of this mutated protein to other neighbor molecule and leads to clumping of hemoglobin. And it's a reversible process. I mean, when you oxygenate, then it will happen back again. But when it's repeated and continued hypo or deoxygenated, it will be problematic. And that's the reason for main problem. Now, I think we will leave maybe questions to the end, but of course, anybody have a very quick questions can ask. I don't have access to the chat now. I am just looking at my slides, and maybe Ralph or somebody else can help me tell me the questions.
That's fine, Mushin. Jerome can keep an eye on the chat for you.
Thanks.
Okay.
Now, the next one is just epidemiology. It is, we all know that this is one of the most common monogenic disorders worldwide, single gene disorders. The prevalence of sickle cell disease varies from region to region. Migration is changing the global picture of the disease. We all know. Estimated 275,000 newborns every year. 2/3 in sub-Saharan Africa. Almost all newborns in well-researched countries survive to adulthood. Median survival of sickle cell improved dramatically nowadays. Now, prevalence here in UK, it's 12,000 to 15,000. 70% of them live in Greater London. So approximately some 350 new births per annum. We have an NHR, which is National Hemoglobinopathy Registry, which register all new sickle cell disease or all new thalassemia hemoglobinopathies. We have approximately 350 adults patients at London Northwest NHS Trust. Now, if we go to the genotype, it's an autosomal recessive disease. So you need two S genes to get the disease. One from mother, one from father. So individuals get this SS sickle cell disease, which we call it sickle cell anemia. So sickle cell anemia is confined to the sickle cell SS genotype. The other probabilities, there are other mutations, not S, combined with S, leading to sickle cell disease as well. And I'll come back to them. For example, is hemoglobin C. If you have an abnormal hemoglobin like hemoglobin C and the partner has S, so there is a likelihood that child, 1 in 4 likelihood child will get SC, which is a sickle cell disease. Now, if it is only one single mutation, one single gene, then it's a trait and it's not considered as a sickle cell disease. So these are summary of genotypes. The major one is SS, SC, S beta 0 thalassemia, S beta plus thalassemia. Beta 0 thalassemia means that you don't have any beta chain, so 0. Beta plus thalassemia, you have element of beta chain, whether it's 10% up to 40%, maybe up to more than 50%. We call it beta plus thalassemia. Usually beta plus thalassemia is mild because you have some A, hemoglobin A as in certain percentage. There are rarer type of sickle cell disease, which is hemoglobin S combined with hereditary persistence of fetal hemoglobin, or D Punjab, or Lepore, or even delta beta thalassemia, which is different from Lepore, and or Arab. So these are rarer types. It can be found different geographical areas. So some areas are mainly S or Arab, some areas are mainly SS, some areas are mainly SC. But the most common types are SS, SC, S beta 0 thalassemia, S beta plus. And the most severe type is SS and S beta 0 thalassemia. Because S beta 0 thalassemia, you will have only S. So it's like SS. Now, the organization, how you organize work in UK, we have a national hemoglobinopathy registry. The purpose of it is means of monitoring the number of affected adults in a clinical center, for adverse event recording, and for demonstrating compliance with key standards of clinical care. The service provision and commission model. So the top is National Hemoglobinopathy Panel, which take over and discuss the complex cases. Among them, maybe the candidate for transplant, bone marrow transplant, and overseeing all activities of other centers. The next one will be HCC, which is hemoglobinopathy coordinating centers. We have 10 of them in UK, and Imperial is one of them for sickle cell disease, which holds a lot of MDT meetings and cooperates closely with the specialist hemoglobinopathy centers and with local hemoglobinopathy centers or trusts. Meetings for morbidity and mortality, meetings for approval of new medications, meetings for complex cases and other issues. A specialist hemoglobinopathy trust is also a less big trust, which have a specialist service for hemoglobinopathy, and they cooperate with guidelines, advice to the local hemoglobinopathy trust in district hospitals. And then the local hemoglobinopathy team is usually the district general hospitals. Now, back to the very quickly to pathophysiology. So as I mentioned, the single mutation, glutamine to valine leads to all these sickling problems under deoxygenation. So when there is deoxygenation, red cells will deform. Under these conditions of reduced oxygenations, hemoglobin will polymerize. And a lot of polymerizations of hemoglobin lead to a distortion of the red cell shape, like sickle shape, and becomes very rigid and injures the endothelium. And if they become stick to each other's, injures endothelium, they do not flow well through the small vessels. This is the main pathogenesis of vasoocclusion of the arteries, which leading to ischemia and necrosis of the target organ. So they do not flow well through small vessels and increase adherence to vascular endothelium and vascular occlusion and crisis. Now, this is the polymerization. So under hypoxic conditions, hemoglobin S undergo polymerization, and this polymerization leads to distortion of the shape of the red cell, becomes rigid, sickle shape, and that causes endothelial tearing and stick to each other and causing obstruction of the vessels. Now, these the inflexibilities, so they are not flexible. The rigid sickle shape red blood cells contributes to their premature destruction and then byproducts of hemolysis, causing even further endothelial inflammation and damage. So you will see high bilirubin, you will see high LDH, you will see a lot of other stuff which can cause problems, and you will see decreased nitric oxide, which causing also further vasoconstriction and endothelial damage from lack of nitric oxide because of hemolysis. I mean, it's chronic hemolysis. So vasoocclusion, what will happen then? Early damage and micro tearing to the blood vessel wall. This will induce an endothelial inflammation and may lead to chronic vascular damage. So the process is not only just sickle cell become rigid and sickle shape and stick to each other and block the vessels. No, the main issue is endothelial damage here, which leads to chronic vascular damage. Chronic vascular damage, of course, it is a complex pathophysiology. It's not only just single red cells. It's not affecting only red cells. It's beyond red cells. And over time, you will see that this ongoing damage, repeated injury to the blood vessels, will result in activation of endothelial cells. So endothelial cells will be activated. And then this chronic inflammatory environment, blood vessels leads to increased expression of adhesion molecules. There are some adhesion molecules come up in the system and blood cells inducing multicellular adhesions. It's not only adhesion of sickle or red cells, it's adhesion of white cells and platelet and endothelial cells, multicellular adhesions because of these adhesion molecules. I think one of my colleagues will talk about the new medications, and there are so many new medications targeting these adhesion molecules to stop the process. Now, multicellular adhesion, as I mentioned, so red blood cells, white blood cells, and endothelial cells causing stuck to each other, causing damage and block to the blood vessels and block to the flow to the organs, lead to organ damage anywhere in the body. Vasoocclusion, of course, is a complex cascade interaction, all these cells and endothelial and adhesion molecules, and leading to blockage, vasoocclusion. Painful crisis is a blockage to the bone marrow, so it's painful crisis. Chest crisis, blockage to the lung, and so on. So reduction in blood flow, of course, when you block the small arterioles or capillaries, the reduction in blood flow after that will lead to further hypoxic conditions, and then again polymerization again, and will be vicious circle. So anemia, of course, decreased number of red blood cells due to premature destruction, as I mentioned above, leads to lower hemoglobin level and subsequent anemia. So the visible thing is only pain, but it is inflammation and cell activation, multicellular adhesion, and vasoocclusion. I don't want to do much about pathophysiology, but leads to end organ damage. Vasoocclusion lead to, of course, it's many multi-organ damage, and end organ damage is one of the clinical phenotypes of the sickle cell. So clinical phenotypes, we have 3, patients can present with anemia. Can be usually stable hemolytic anemia, very tolerable, but it can be aplastic anemia when drops quickly more than 2 gram or even more with parvovirus or any other causes of aplastic anemia, or even hyperhemolysis. They can get malaria infection and get a further hemolysis on top of chronic hemolysis, so dropping of basal stable hemoglobin. So we need to always to know the stable basal hemoglobin of the patient. And also can present with, for example, hemolysis due to blood transfusion, like delayed transfusion reactions or hyperhemolysis. These are also anemia. Vaso-occlusive crisis. These are, we know, painful crisis, acute chest crisis, can stroke. Child with 5 years old, 10 years old coming with a big stroke, vaso-occlusive crisis. Chronic organ damage, which is a result of combination of both, and hemolytic anemia and vaso-occlusive crisis. So it will lead to pulmonary hypertension, to nephropathy. Spleen will be non-functioning because of repetitive, usually silent crisis, occlusions and damage. So non-functioning spleen. So acute complication, early pediatrician knows that early they get dactylitis, swelling and pain of the hands, and there are also sequestrations where pooling of blood coming into the organs like spleen and liver and trapped there. So the organ will become more painful and tender, and there is also hypotension because a lot of blood trapped there. And usually, if you give them a blood transfusion from the first unit, they may reverse the process and come back normal. This is sequestration, mainly in the liver and spleen. Aplastic crisis, as I mentioned, it can be parvovirus, parvovirus 19, with switch off, attack the arthroblast in the bone marrow and switch them off. And usually in normal persons, it doesn't matter because then the virus will take about a week or so and become fine. Patients has no any problem. But in sickle cell, because the turnover around is very quick, hemolysis and need more reticulocyte high, more, then it will be appear that it's dropping hemoglobin quickly. Acute pain crisis is one of the acute complications. Acute chest syndrome, increased risk of infections. Of course, most of them by the age of 5, they don't have function spleen. I think it is about 95% of them, they don't have any functioning spleen at the age of 5 because of repetitive, even silent vaso-occlusion crisis of the spleen, damaging spleen, no immunity, especially encapsulated bacteria. So increased risk of infection. Priapism is one of the complications as well, which needs urgent attention, strokes and subarachnoid bleeding. Chronic complications, of course, fatigue, anemia, nephropathy, one of the also end organ damage, pulmonary hypertension, end organ damage. And that's why we do screening by echo from age 18 and above every 3 to 5 years or according to the patient's symptoms. Chronic sickle lung disease can happen, gallstones because of hemolysis, avascular necrosis in the bones, leg ulcers, retinopathy. They need a screening annually by eye specialist, ophthalmologist. Iron overload, especially if they are on top-up or transfusion or even exchange transfusion. Osteopenia, growth, puberty, and fertility problems. These are summary of, so all organs can affect it. So it's a systemic disease. It's a vasculopathy, endothelial disease, systemic disease, which affecting everything. There is NCPOD report in 2008, which a sickle crisis. Principal recommendation of that report was that they recommend that in General Medical Council, in our multiracial society, it's essential that all doctors should have a basic understanding of the implications of thalassemia and sickle cell trait. And also, as a minimum, the Department of Health guidance regarding vaccination and prophylactic antibiotics should be followed in to prevent sepsis from hyposplenism. Primary care trust. Multidisciplinary and multi-agency approach is needed in the ongoing pain management for patients with sickle cell disease. Outside hospital, majority of the patients, but needs to cooperation with primary and secondary care. Patients with sickle cell disease or beta thalassemia major should be managed by or have access to clinician with expertise in hemoglobinopathy management, both primary and secondary care. Also, healthcare center responsible for management of patients with hemoglobin should have access to protocols, guidelines, and also national database of hemoglobin should be developed and maintained to include standard information of mortality and morbidity. Now, standards of care issued by Sickle Cell Society, which they precise about they should be registered in GP, should have good communication with secondary care, they should have offered vaccinations, and the specialist team should develop locally agreed care protocol with GP to define the roles and responsibility of each. Now, the strength of primary care is direct involvement with the patient, as you are aware, their home support, network, environment, greater awareness of social, economic, family, and psychological life. I'm sure you do some genetic screening, routine screening, management of other comorbidities, and health advice. And specific responsibilities, each treatment. So, I mean, it's important to treat the infections as early as possible to prevent sepsis. They are immune compromised. They are at risk of infection at any time. So prescription of antibiotic prophylactic is important, ensuring vaccinations are up to date, early referral of pregnant women and reproductive advice, referral for psychology support, encourage treatment compliance, patient education and self-management of mild painful episodes, support during transition and move to further educations. If a child is diagnosed with sickle cell disease, specialist nurse inform the GP and health visitor. Child referred to local hematologist, pediatrician. Parents receive appropriate education, and GP should prescribe prophylactic penicillin to start as soon as possible and at least by age of 3 months. This is very important. That's why we do screening of sickle. It's not just to tell parents that you have a child with a sickle. No, it's to give penicillin, and if they are allergic, give erythromycin. So penicillin to start as early as possible. Of course, to start screening for stroke by TCD, I think it's at age of 2. Prescribe folic acid, ensure child receive full vaccinations in accordance to national schedules. And also the infection in sickle cell disease, invasive pneumococcal disease, encapsulated bacteria. Haemophilus influenza B, and pneumococcal, meningococcal, and also salmonella, gram-negative UTIs, complications following influenza, and vaccinations in green pox. I think I'm all aware. We have a standard paper. We usually send it to attach to our clinic letter to the GPs, especially for all new patients coming. This standard letter will include all the vaccinations needed for this group of patients, which involve Prevenar 13, Haemophilus influenza B, meningitis C, meningococcal B, and meningococcal ACWY, in addition to pneumovax. Pneumovax should be considered at age of 2 years and repeated every 5 years. Hepatitis B from age of 1 year, especially if receiving blood transfusion, and annual flu vaccine, of course. Vaccination in adults, as I mentioned, this is all written in our standard paper sent to clinical with a clinical letter. Antibiotic prophylaxis is important to prevent any pneumococcal infections, especially in children. Traveling, you need to give a malaria prophylaxis, and you need to give appropriate travel vaccination as usual. Blood pressure monitoring, you need to target the blood pressure below 140 and 90 in the absence of proteinuria. If you have proteinuria, you need to target the blood pressure below 130 and 80. First line treatment is calcium channel blocker. Avoid diuretics as first line treatment to make sure that there is no risk of dehydration. Folic acid is important, 5 milligram once daily. Important during periods of illness. You need to check the levels if there is any macrocytosis. And of course, pregnancy, you start 5 milligram once daily anyhow if they are not already on. Vitamin D deficiency. We see many patients with vitamin D deficiency and aches and pains and related to vitamin D deficiency. We know that there are so many people. They are the many studies show they are higher susceptibility for vitamin D deficiency. So we need to check it annually. Lung disease, ensure symptoms and chest pain. if there is any chest pain symptoms, you do chest X-ray, O2 saturation, inform hemoglobinopathy team or A&E if it's urgent. Renal problem, GPs to avoid NSAIDs and other nephrotoxic drugs if possible, control blood pressure as I mentioned above, treat UTI. Urine dipstick is very important, and we check usually protein creatinine ratio as annually, because one of the screening of microalbuminuria, which is exactly the same of when you do the diabetic microalbuminuria, it's reversible. So that's why we start for AC inhibitors if it is persistent. We confirm that in another test, and if it's persistent, we do start with AC inhibitors. We check UNEs, review iron chelation, and if XJADE, if any renal impairment, you stop XJADE and refer to team, hemoglobinopathy team. Iron overload, we know 3 types of, we have dyspheral, which is dysferoxamine subcutaneous infusion. There are yearly follow-up with hearing test and also ophthalmology. Deferriprone can be agranulocytosis, zinc deficiency, arthropathy, and XJ, GI upset, deranged liver functions test. So aim of treatment actually is to reduce frequency of vaso-occlusive crisis, prevention of chronic complication, improve the quality of life, enhanced life expectancy. The main treatment is hydroxycarbamide. Standard treatment is either exchange transfusion or hydroxycarbamide, and now is crizanlizumab with monoclonal antibodies. Hydroxycarbamide, of course, reduce frequency of painful crisis, acute chest syndrome, transfusion requirement, length of stay in hospital. Mechanism of action is promotes fetal hemoglobin synthesis, improve red cell hydration, modifies red cell endothelial interactions, and donor of nitric oxide as well. Side effects, many side effects, but we don't give it in pregnancy. We don't know the teratogenicity. And I'm not aware of any leukemia or other malignancies from hydroxycarbamide. It has been more than 25 years or more than that using a sickle cell without any problem. It's causing neutropenia, yes. Thrombocytopenia, yes. And we need to act on. So stop hydroxycarbamide if neutrophil count below 1.5, platelet below 80, or hemoglobin under 55, or drops by more than 20% from baseline. If patient has fever or infection, we stop it for a few days and restart on recovery after checking full blood count. If they have leg ulcers, we stop it. Admit to hospital if neutropenic sepsis. Of course, if neutrophil count below 1 with fever, it needs admission to the hospital. Sickle emergencies, urgent admission. If you have a patient with severe bone pain requiring opioid analgesia, you need to admit to the hospital. Is it bone crisis? Is it osteomyelitis, septic arthritis? If they have increased pallor, breathlessness, exhaustion, of course, is that anemia, exacerbation, parvovirus infection, sequestration. If it is fever, marked fever, more than 38, tachycardia, tachypnea, or any one of them, you need to admit to the hospital to exclude chest syndrome or sepsis. Of course, desaturation is important, below 95% on room air, to exclude any PE or acute chest syndrome or pneumonia. You need to urgently admit to the hospital. Severe chest pain, back pain, you need to admit to the hospital as well. Abdominal pain, distension, diarrhea, vomiting, you need to think about girdle syndrome, think about gastrointestinal infections like Yersinia. Other emergencies needs admission is if the patient is on deferoxamine, deferoxyrox, or deferriprine, you think about Yersinia infections. Also, if it is significant headache, drowsiness, think about stroke, TIA, or other CNS abnormalities. Fulminant priapism lasting more than 3-4 hours. You need to give prompt analgesia, empty bladder, and refer immediately, especially if it persists more than 3-4 hours, because they need to do aspiration, red cell exchange, and maybe even shunting procedure to prevent any permanent damage. So general management of acute sickle crisis, of course, analgesia, ideally within 15 to 30 minutes, hydration, oxygenation, keep them work, identify and treat the infection or any triggering cause, re-evaluation. Acute chest syndrome, it is a hospital issues, but any symptoms can give you a clue. You need to send the patient directly to the hospital. So any patient with suspected acute chest syndrome should be urgently referred to the hospital. Signs of symptoms of stroke you all are aware of. Any symptoms and signs of stroke need to immediately. Multidisciplinary team is important, including psychologists, social workers, dietitian, chronic pain service, and physiotherapist. Other rules of GP, of course, you have some transition, moving patients to schools, universities, house, home, transition from pediatric to adult, or those people who DNA a lot, and also people who need social support and who need repeat prescriptions. They are mainly GP role to give that. Conclusion, it's a chronic multi-systemic disease, which are sometimes life-threatening and unpredictable. That's the main issue. It's unpredictable. Vaso-occlusive crisis can lead to acute chest syndrome after 1-2 days, can lead to other complications, very rare complications like fat embolism. It's unpredictable and require lifelong medical and psychosocial care. Important public health issue for NHS. Good care, of course, improves the expectancy and quality of life. Good care reduces the disease complications, stroke or hospital admissions. So it is very important to have a good cooperation between primary care and hospital care, two-way. It's not only the clinic letter, but good communications like about vaccinations, repeat prescriptions, standard care plan, individualized care plan for any patients. I'm really sorry, I'm very quick for a few slides, but because of I'm concerned about the time. And thank you. And
Absolutely excellent.
these are the
Really informative. No,
my yeah, thank you very much.
No, excellent. I don't know whether there are any questions, but I want to personally thank you, as Ralph said earlier on, for filling in the slot. Really informative. If there are any questions, Dr. Almusawy is ready to answer any questions you may have. No. Okay.